Hello, my name is Carsten Bantel and I'm a consultant in pain medicine here at Chelsea Westminster Hospital in London, United Kingdom. And I would like to give you a quick introduction into pain assessment tools. Pain is a subjective experience, and that's the reason why it cannot be objectively measured. Hence, pain can only be assessed, and this is important to remember. At the moment, we are facing a dilemma in pain medicine. Because the cause of pain is frequently unknown, we as clinicians are reliant on unspecific symptoms to treat our patients. This is aggravated by the situation where research is actually failing to provide us with new therapies. However, scientists and clinicians both think that it is necessary to better characterize painful conditions to provide actually new solutions for its treatment. Hence, at the moment, there is a kind of new trend which basically can be summarized under the headings of phenotyping and biomarker research. What are biomarkers used for? They should be used ideally as diagnostic aids. They should help us to stratify patients to best treatments, and also they should enable us to tell patients about the prognosis of their disease. Biomarkers can be classified in general into 7 groups, 0 to 6, and group 6 are interestingly clinical scales. And in pain medicine at the moment we are using group 0 and 6 for pain assessment or as pain assessment tools. 2 main principles are applied to pain assessment tools. The first one is patient self-reporting, and the second one is reliant on external observations, and hence they are called proxy assessments. Self-reporting tools are currently the preferred tools for all cognitively and verbally competent patients, because they actually allow or assure the sovereignty of patients over their own private experience and hence avoid the interpretation by external parties. There are 2 different types, uni and one-dimensional assessment tools and multidimensional assessment tools. Let us start with the visual analog scale. A classical visual analog scale is a horizontal line which is normally 10 centimeters long. It is anchored on the left hand side with no pain and on the right hand side with worst possible pain. A patient is then asked to mark the spot on the line which they think, or he or she thinks, best represents his or her pain. A ruler can then be applied to measure the distance from the no pain spot to the marked spot to give a direct indication of pain intensity. Verbal rating scales, and it should not be NRS, it should be VRS in this case as an aberration, actually applies verbal descriptors of pain or for pain. Normally it's no pain, mild, moderate, severe or very severe pain, but it can also include more or less verbal descriptors. A patient is asked to mark the word which he or she thinks best represents his or her pain intensity, and this is a direct indicator then for his or her pain experience. However, the criticism people have, or the issue people have with visual analog scales is that they require translation of a sensory experience into a spot on a line. Further, it requires patients to have an intact motor and coordination system. And as you can imagine, if you think about your elderly patient, that might actually be a problem. Further, in the classical way, people think about visual analog scales as continuous scales or even ratio scales. However, this might not be the case. Also, verbal rating scales are categorical data, and sometimes you read actually papers where verbal rating scales have been analyzed with parametric tests. Although this is a slightly different story here, I'm basically drifting off into statistics. However, this is not accurate because categorical data should always be analyzed with non-parametric tests. Also, there is more and more evidence to suggest that patients actually prefer verbal rating scales over visual analog scales, or in other words, all data at present suggests that visual analog scales are the least preferred ones in daily clinical practice by patients. Another thing to consider is if you do or if you employ verbal rating scales, you have to be careful that actually the scale is validated for your patient cohort. What I'm trying to say is basically that the meaning of words might be different from depending on the patient's background. So just be careful with the wording you are using for your verbal rating scales. Numeric rating scales are in many ways similar to the visual analog scale. However, in contrast to the visual analog scale, they can exist in many different forms, and I will explain to you the two forms we are currently using in our clinical practice. The first one is the 11-point numeric rating scale, which you might have come across in your clinical practice. As you can see, it is a straight line, but in contrast to the visual analog scale, it is subdivided into equal intervals. Also, it is marked or anchored on the left-hand side with no pain and on the right-hand side with worst possible pain. Again, a patient is asked to mark this spot on the line which he or she thinks best represents his or her pain. But as you can see, you don't need a ruler or anything like this to basically measure the pain, but instead the number is used as a direct indicator for the patient's pain intensity. We are also using a 5-point numeric rating scale, which is actually from 0, which equals no pain, to 4, worst possible pain. But I know that other hospitals, for example, using a 4-point numeric rating scale, which ranges from 0 to 3. And again, the patient is asked to mark the spot or the number which he or she thinks best represents his or her or his pain. The thing is, again, if you look at the literature, and this is a slight excursus into statistics again, a lot of people believe that numeric rating scales are actually continuous data, which is not true. As a matter of fact, the shorter the scale, the more likely it is that these scales represent ordinal data. Also, although you might think that the interval between each mark is identical, this is so far not really established by research. Also, as I said to you before, some patients actually prefer numeric rating scales over visual analog scales or verbal rating scales. However, there is evidence in elderly populations that they might prefer verbal descriptors over any form of numeric rating scales or visual analog scales. And similar to what I said about the visual analog scales, the numeric rating scales also require the patient to translate a sensory experience into a number on the line. And we have now evidence to suggest that this translation is not always accurate and doesn't always work as we think it works. Finally, for our younger patients, meaning the children, we've got pictorial rating scales. The one you probably have seen in many textbooks are the FACES pain scale. In this case, it's the revised pain scale because it contains 6 pictures of faces. The original one contained 7. And again, the child is being asked to basically indicate or point on the face which he or she might think best represents her pain or discomfort level. And then there is the Wong-Baker FACES pain scale, which I prefer because it's basically comic, or it contains comic representations of faces, and to some extent I've got an affinity for that, so I like them better. And it's the same principle. So basically the patient has to indicate which face best represents his or her pain. However, there is research out there which suggests that actually children don't choose these faces because they best represent their pain. These research actually suggest that they sympathize with the faces, and hence these scales become a measure of affect rather than pain. And also another thing is, another unsolved problem in pain research, or in clinical pain even, is when should we be using the faces pain scale, or in other words, when is a patient or a child able to self-report? Now I come to the multidimensional pain assessment tools. And there are three different types. The first one, or the first type, judges the impact of pain. The second one assesses the quality of pain. And the third one are pure screening tools, or coming back to our biomarker story, they are group NORD biomarkers, and they are used for phenotyping of pain. Most of these multidimensional assessment tools are based on questionnaires. However, sometimes these questionnaires are going in conjunction with rating scales. Sometimes even they are required, or clinicians who apply them are required to do specific clinical examinations in conjunction with these multidimensional assessment tools. Multidimensional assessment tools, as the name implies, assess multiple aspects of pain, such as sensation, mood, pain intensity. I will quickly run with you through some of the commonly used multidimensional assessment tools. For the assessment of the impact of pain in our hospital, we are using the Brief Pain Inventory. For the assessment of the quality of pain, people use the McGill Pain Questionnaire. As a matter of fact, the McGill Pain Questionnaire is probably at the moment, or to all of us, the best known pain assessment tool. Then there is a short form of the McGill Pain Questionnaire, and also there is a neuropathic pain scale, as well as a pain quality assessment scale. As screening tools, especially to distinguish neuropathic pain from, let's say, inflammatory pain, there's the Leeds Assessment of Neuropathic Symptoms and Signs, or LANS. There's the Neuropathic Pain Questionnaire, and there's the Neuropathic Pain Diagnostic Questionnaire. Let me just introduce you to the McGill Pain Questionnaire, and I think you probably all have heard about it. It is basically an A4 form which contains in total 78 descriptors of pain. And these 78 descriptors are organized into 22 groups. The first 10 groups are concerned with the sensory quality of pain, and I've indicated this with this line. Group 11 to 20 are assessing affective, evaluative, and miscellaneous components of pain, shown here. Group 21 and 22 are concerned with pain intensity, and as you can say, per definition, this is probably more a verbal rating scale or verbal descriptive scale of pain. And the images on the form, on the McGill questionnaire, are used for the patient to indicate where the pain is actually located. However, although the McGill Pain Questionnaire is quite well known, there are some shortcomings with this scale or with multidimensional assessment tools altogether. The shortcomings are they of value in day-to-day practice? And this has actually been questioned in recent research. So at the moment, people really think they are more the remit of research rather than clinical work, because there is a question whether they are sensitive enough for the detection of any treatment effect, which is important for the clinician. And also, as you can imagine, going through 78 descriptors of pain, this is actually a lengthy process, and it might not be applicable or not be as good in daily clinical practice because it's just too long. Now we are coming to the proxy or observational assessment tools. But before I do that, I have to go back to the self-reporting tools, because the self-reporting tools are reliant or rely on intact higher cognitive function, which is memory, language, the concept of numbers, and the concept of proportions. However, proxy assessments don't need this, because as the name implies, it is someone else who does the assessment for the patient. But there's a problem, of course, with that, because this actually requires subjective skills of the observer. And this is basically how well can he observe, or she. And also it kind of goes into the remit of clinical judgment. And as we all know, clinical judgment is also a function of clinical experience or maybe even training. So proxy assessments, or the aim of proxy assessments, is actually to make assessments or to standardize assessments to make them widely applicable. Let us first discuss the situation in children. Whenever I do my ward rounds, I'm frequently faced with a situation where trainees or students tell me that why would I assess pain in children, because children can't feel pain anyway. And I'm always a little bit shocked about this statement, because this actually should be, or this kind of statement should have been abandoned many years ago, because now we know actually that children of all ages do experience pain, and hence we have an obligation to not only treat pain but also to assess pain. And this the more because we know that untreated pain in children has a negative impact on their further development. So what type of treatment or of assessment tools should we be using? Now, there's a rule of thumb saying that actually children from about 4 years onwards should be using or should be ready to use self-reporting scales like the Wong-Baker scale or the FACES pain scale. However, younger children need to be assessed with proxy tools, and these tools make use of behavioral cues like crying, breathing, or movements. I don't want to bore you with the presentation of too many proxy assessment tools for children, but it's probably worth looking at the most commonly used one, which is the Neonatal Infant Pain Scale, or NIPS. It is kind of validated for children of less than 1 year old, and as you can see, it makes use of the facial expression of the child, of the crying behavior, breathing pattern, of arm movements, leg movements, and a state of arousal. And as you can see, each component can be scored, and at the moment we think that a score of greater than 3 indicates pain, and or not only indicates pain, but pain that should be treated. Let us now discuss the situation in our demented patients. Dementia is regarded as the prototypical cognitive impairment. And people believe, or still believe, that if a patient is demented, we can't use self-reporting tools to assess their pain. However, there is evidence to suggest that this is not true. As a matter of fact, now there is good evidence to suggest that mild to moderate dementia can be assessed with self-reporting tools. However, the ideal assessment tools or tool in severe dementia should incorporate multiple aspects of pain, such as sensation, behavior, and emotions. However, unfortunately, the currently used assessment tools are not very well validated at present, and they also only cover some aspects of pain. Currently used tools in dementia are pain assessment tools in advanced dementia, or PAIN-8, pain assessment checklist for seniors with limited ability to communicate, or PACSLAC, and finally the DOLO Plus scale. or assessment tool. To give you an idea of how we are assessing pain in the demented patient, or to be more precise, in the severely demented patient, I'm giving you the example of the PECSLAC assessment tool. Similar to what we've seen in our children, or in the pain assessment tools for children, it relies on patients' facial expression, body movements, social, personality and mood symptoms, as well as other symptoms. Now, the observer simply has to mark whether a symptom is present or not. So hence, with this assessment tool, we are dealing with binary data, and the maximum score a patient can achieve is 60. However, one of the biggest drawbacks with this assessment tool is that we don't know which score truly reflects pain, and more importantly, which score reflects pain that needs to be treated as a matter of urgency. Now, let's carry on to look at patients in the critical care environment. There's a special challenge to the pain assessment in critical care, because, as we all know, patients in severe pain in critical care might experience an adverse outcome because of the activated sympathetic nervous system. This might actually aggravate their disease process. Also, pain on intensive care is difficult to recognize because of the underlying medical condition of treatments we have given, for example, beta blockers or sympathicomimetics. And also, self-report is usually not possible in patients on intensive care. Hence, we are reliant on proxy assessments. And again, similar to what we said about the children or the demented patients, these assessment tools rely on behavioral cues and physiological signs such as heart rate and blood pressure. There are many proxy assessment tools available at the moment for critical care patients. They might be unidimensional or multidimensional, and I'm quickly running you through some of the unidimensional tools. The first one is the Behavioral Pain Rating Scale, or BRPS. There is the Behavioral Pain Scale, or BPS, the Pain Behavior Assessment Tool, BPAT, and the Critical Care Pain Observation Tool, CPOT. As multidimensional assessment tools, we know the Pain Assessment and Intervention Notation, or pain algorithm, and the Nonverbal Pain Scale, NVPS. However, most tools at the moment are not readily or adequately validated. Let me now quickly go over a commonly used assessment tool in critical care, which is the Critical Care Pain Observation Tool, or CPOT. And similar to what I already discussed with you when we looked at the pain assessment tools, proxy assessment tools in children and in demented patients, also the critical care proxy assessment tool is reliant on behavioral cues like facial expression, body movements, muscle tension, and what I found interesting as well as the compliance with the ventilator or vocalization if the patient is already extubated. Now, similar to all the other tools, the observer now is asked to rate the symptoms, and with this CPOT assessment tool, the patient can actually, or the highest score the patient can be given is an 8. So the range of scores is from 0 to 8. However, similar to what I said with the other assessment tools, at present we don't know what score represents a treatable pain. Now I've come to the end of my talk about pain assessment tools, and let me quickly summarize what we have discussed this afternoon. Pain assessment tools are biomarkers, and there are a plethora of tools out there which are ready to be used. However, this in itself tells you a story, because at present there is no ideal pain assessment tool out there. However, you as a clinician or maybe clinical scientist should know about the strengths and weaknesses of the currently available tools to make best use of them in your practice. Thank you very much for your attention.